Thank you, Paul. Good morning, everybody, and thanks for coming here today, this early in the morning. As Paul has already indicated, I will be talking about 4D treatment planning, the rationale, methods, and the significance of doing so. Excuse me. As we all know, the image data that is acquired using conventional methods have artifacts because of the respiratory-induced motion. And this is important because it generates a chain process. Artifacts in the images means inaccurate anatomical information, which in turn means inaccurate dose evaluations and from here, inaccurate dose treatment outcome correlations. So in response to this challenge, the 4D solution has been proposed, which basically means that we now have available an image acquisition technology that includes a temporal dimension on the time scale of the breathing period. And at the end of this, we are provided with multiple image data sets that correspond to various phases over a breathing cycle. So assuming that we have accurate 4D image data available, there are a number of questions one can address in relation to the next step, which would be 4D treatment planning. So one can or has to wonder first how we can factor the more complete and accurate image data into those calculations, how much image data is needed, how does the dose change in 4D compared to three-dimensional based treatment planning, and of course, at the end, what are the endpoints of all this? So let's first discuss about how we can incorporate more image information into those calculations. The term that is usually used in conjunction with 4D treatment planning is dose mapping. And to describe what this means, I will use this little cartoon here. Shown here are two data sets, of which one is called planning data set and will be used to score these cumulative doses. Superimposed here is the dose computation grid, and the dots are indicative of the center of all these dose grid voxels. Dose mapping basically is an anatomy-based summation of doses as opposed to just adding up doses from corresponding voxels. And in order to perform such type of dose calculations, there are a number of steps that we have to follow. The first step, of course, would be to come up with a plan and do some dose calculation. But once these dose calculations are available on a number of data sets, the process starts by looping through the voxels from the planning or reference data set. And the first thing that we need to do is to figure out how these voxels deform during breathing. And this is something that is accomplished by using an image registration process. The next step is to somehow figure out what is the dose deposited in such deformed voxels. And the last step will be to accumulate the dose from the deformed voxels back into the voxel from the reference data set, using usually some time weighting coefficients which are required because different amounts of time are spent at various phases of the breathing cycle. So being able to evaluate the dose in this deformed voxel is not necessarily an easy task because those computations are usually performed on a voxelized geometry. So let's see what would be the simplest way to try to evaluate the doses when we move from one data set to the other. So if we think, for example, about a Monte Carlo dose calculation algorithm, we know that the dose in each voxel is going to be the average energy deposited inside that voxel, and it's usually reported at the center of the voxel. So from here, it's intuitively clear that the simplest way of evaluating the dose received by this voxel on a different data set would be to just map the center of the voxel onto the other data set to evaluate the dose at this location, for example, by doing a simple trilinear interpolation. And after that, of course, we accumulate the dose back using time weighting coefficients. However, in cases when deformations occur, and particularly if they are large and occur in high dose gradient regions, calculating the dose or estimating the dose in the deformed voxel by the dose at the tract center may no longer be sufficiently accurate, because as you can see here, we could be in a situation where we have those grid points that fall inside this expanded voxel that are no longer accounted for if we just do simple trilinear interpolation. So the first thing that comes to one's mind is to perhaps try to do a finer interpolation, which means that we start by subdividing our original voxel into smaller subunits, and then we map the center of each subunit onto the other data set. We evaluate the dose at each of these locations by doing the simple trilinear interpolation. And at the end, the dose in the deformed voxel can be approximated by the average value of these individual doses from the tract subunits. And from here, again, time-weighted sum of the doses from various voxels to get the cumulative dose. The question is, how do the simple and the finer interpolation compare to each other? And see here, I'm showing those difference displays between doses computed using either one of these two interpolation approaches. Of course, we are talking about interpolation, so it is not a surprise that the differences between these two interpolation schemes are most obvious in the high dose gradient regions. And also because we are talking about interpolation, it's again not a surprise that the magnitude of these differences is going down as the grid size decreases. Now, the major problem with this interpolation approach is that it does not account explicitly for changes in doses in those deformed voxels. So, in order to accommodate this aspect, Emily Heath and Jan Junsen from McGill University have proposed what they call direct voxel tracking method. So, first of all, in order to be able to pursue this approach, they needed a Monte Carlo-based dose calculation algorithm. And what they did is that instead of doing the computation of the dose in a voxelized geometry of rectangular voxels, as it is usually done, they have actually performed particle transport inside these deformed voxels. And as you can imagine, this is a rather time-consuming process because it is not easy to track particles inside irregular boundaries. And there was also an approximation that they needed to do for the boundaries. The surfaces of these voxels, the sides of the voxels are not very well known because usually the image registration process is focused on how the vertices move. So they had to approximate these surfaces by two planes as suggested in this cartoon here. But perhaps the biggest problem still remains here, the amount of time required for performing such those computations. In response to this, Hualiang Song and Jeff Siepers from VCU proposed yet another approach, which they called energy transfer method. And as the title of their method suggests, there is a big departure in some respects in this approach versus the previous one, in that they do not track doses anymore, they track energy deposition events. And to understand how this works, let's look at this example here. Let's assume that on some given data set of interest, there are two energy deposition events that occur at these locations called A and B here. And let's assume that the image registration maps these two locations inside this voxel from the reference data set. Then in this case, the dose, the accumulated dose to the voxel of interest would be a time-weighted sum of the energies deposited at these locations divided by the mass of the voxel. The direct voxel tracking method and the energy deposition method have been compared to the interpolation-based approaches, and nonetheless, differences exist, and they usually occur in high-dose gradient regions. But it is true across the board that the magnitude of these differences will decrease as the voxel size decreases. The good part about the interpolation methods is that they work with any dose calculation algorithm. They don't necessarily require a Monte Carlo dose calculation engine. But on the other hand, the direct voxel tracking and energy deposition are potentially more accurate. But again, they require a Monte Carlo dose calculation engine. So now that we know how to compute cumulative or so-called 4D doses, let's quickly see what is a typical workflow for 4D planning. And I will use this diagram from a paper by Paul Keel published in 2004 to iterate to this. So we start off by creating deformation fields between various image data sets that are available. Then we move on to define the anatomy of interest on the reference or planning data set. Next, we define the anatomy as needed or if needed on the other data sets. Next step is to create a plan and compute doses on the reference data set, and then create plan and compute doses on the other data sets. And here comes the step where we accumulate the doses. And at the end, the treatment evaluation metrics are evaluated on the accumulated dose that was computed on the reference data set. And if the result is not satisfactory enough, then we can go back and reiterate through these steps as needed. So there are a number of practical considerations in relation to 4D planning. First of all, there is a huge amount of image data that is available and that requires increased storage space and also increased time to contour. Fortunately, as far as the contouring goes, there are simplified approaches available, such the maximum intensity projection function that is available for automated ITV generation. And also there are automated contour propagation tools that became available. Another aspect is that image registration is required, and this is time consuming, and also errors can be introduced, and the magnitude of these errors and the propagation of these errors are still active research topics. In addition to that, those computations on multiple data sets are time consuming. Of course, unless a Monte Carlo dose calculation algorithm is used, in which case any number of those computations will basically require the same amount of time as one calculation only. However, one Monte Carlo calculation alone still takes longer than a dose calculation performed with any other dose calculation algorithm. On the positive side, though, computational power increases continuously, so it is possible that actually the execution time may drop significantly in the future, such that the time required for multiple dose calculations will no longer be an issue. And last but not least, 4D dose calculation is not available yet in commercial planning systems. There is one vendor that has this capability available in a research version, but today that's about all there is available. So all these things considered, it came naturally that a number of investigations have focused on finding methods to simplify 4D computations while trying to preserve a level of accuracy comparable to that is otherwise offered by a full 4D dose computation. So let's look at some studies that in one way or another address the question of how much image data is needed for treatment planning. In a study conducted at the University of Michigan, doses were first computed based on 11 image datasets available between exhale and inhale. And that cumulative dose was compared with cumulative doses obtained using a decreasing number of intermediate states. So 6 phases, 2 phases. In this case, exhale and inhale doses were considered only. And also, a comparison was performed with just the dose computation that was performed on the data set that corresponded to the average position over the breathing cycle. So, as you can see here, while differences exist, they are usually small, and more importantly, they are rather small compared to the differences that we see between a 4D and a 3D computation in the first place. The color code here is a little bit misleading, but I have intentionally enhanced the colors just so that they can be seen from where you are sitting. The equivalence between various cumulative doses or cumulative doses based on various number of intermediate data sets is also evident when we look at DVHs, for example. You can see here that if we look at doses from individual states, they spread rather nicely between exhale and inhale. But then when it comes to the cumulative dose, regardless of the scenario that we are using, the DVHs tend to cluster together somewhere in the middle and around the DVHs that are calculated on the time average data set. The problem of using smaller number of data sets for those computation could be rather tricky when we have IMRT plans, because in IMRT we have to deal with a lot more gradients. So in a study performed by Stella Flampuri and her colleagues at MGH, they have looked into this aspect. And over the 6 patients that were involved in the study, they found out that in less than 2.5% of the CTV volume, there was a dose difference more than 3% of the prescribed dose between the 3-phase composite dose and the 10-phase composite dose, which seems to suggest again that even in IMRT, it might be possible to be able to evaluate cumulative doses using a smaller number of image data sets. So as you can see, using some type of average location seems to be an interesting option. And I am showing here some results from a study performed by Vanessa Mexner and her colleagues at NKI. What they did was first they computed the dose on the mid-ventilation, the way they call it, dataset, which is the dataset corresponding to the time average location. Then they took this plan and the dose from the mid-ventilation dataset and just simply copied this dose on all datasets that were available, and then accumulated then the doses on the reference dataset by the methods described previously. And then in the third scenario, they took the plan from the mid-ventilation dataset and actually computed doses on all the datasets available and then accumulated doses. So obviously, doing the dose computation on all datasets would be the gold standard for this study. And as you can see in this example DVH for GTV coverage, just copying the doses on the mid-ventilation data set and then accumulated them seems to give very similar results with the case when we do full dose calculations. Computing the dose only on the mid-ventilation data set, it's a little bit less accurate, but I guess I'm going to leave it up to you to decide whether or not such differences are a big concern or a smaller concern. Altogether, it appears that performing the dose calculation on one data set only, whether we do the dose accumulation afterwards, or whether we do full dose calculation afterwards or not, gives us the same result or very similar results. A very similar study was conducted at the Beaumont Hospital by Carrie Glidehurst and her colleagues. The difference basically between this study and the study from NKI was that at Beaumont they have proposed using the average CT dataset for those computations, where the average CT dataset was, in their case, a synthetic image set that was created by averaging CT densities over the entire breathing cycle. And the pictures shown here indicate that doses in both scenarios, meaning do full dose computation on all data sets or just calculate the dose on the average CT and then copy it on the other data sets and do dose accumulation. So both these scenarios give very similar results. The color wash here corresponds to doses from the average CT approach, whereas the isodose lines correspond to the full 4D dose computation. So fairly good agreement, I'd say, between the two approaches. So both mid-ventilation and average CT approaches presented represent a simplification for the full dose computation because, as I have already said, the dose is computed on only one data set. They provide somewhat improved accuracy compared to the calculation that is based only on some time average data set alone. However, they still require image registration between all the data sets that are available. So at the end of the day, one will have to actually decide between the larger or the smaller gain in dose accuracy and the unknown, unclear effect of registration errors and their propagation and the increased processing time that is required for image registration. Altogether, these studies and others that have not been mentioned in this talk suggests that using some average anatomy location for planning could ensure sufficiently accurate dose evaluation with the least amount of user intervention, which I believe it's important. And also, not discussed here, I would like to mention that separate studies by Dian and Engelsman have indicated that the average patient configuration also requires a minimal margin in order to ensure appropriate target coverage. So let's now look and see how does dose change in 4D compared to 3D dose computations. So the images shown here are displaying dose differences between a full 4D dose computation and the so-called static dose computation that was performed on the XAL dataset. It is important somewhat to mention that the static dose calculation was performed on the XAL dataset because perhaps this is a worst case scenario. You can imagine that if the reference dataset is chosen to be something else between XAL and inhale, then the magnitude of the differences that we see between a 4D dose computation and the static dose computation are likely to be smaller. So the red regions here correspond to areas that move inside the radiation field when we go from exhale to inhale. The arrows here indicate the direction of motion for each tumor from these examples. And then the blue areas are regions that move away from the radiation field, and therefore there would be less dose in those regions in the 4D dose versus the 3 dose. Now, what is important to notice here is that the cold and the hot spots, as they are usually called, in some scenarios, it happened that just either the cold spot or the hot spot falls inside the normal lung. Whereas for the examples that are shown here in the bottom row, you can see that both the hot and the cold spots fall inside the lung, in this case in either one of them, whereas in this scenario, both the hot and the cold spots fall inside the same lung. But this is perhaps a little bit less relevant if we believe that lungs are parallel organs. So this seems to suggest that maybe when we have scenarios like those illustrated here at the bottom, the effect of motion on the lung doses might be less important because the hot and the cold spot tend to cancel out each other, whereas some changes that may or may not be clinically important could be expected in those cases where either the hot or the cold spot fall inside the normal lung. And I guess if you keep this, these pictures in mind, it would probably perhaps be pretty intuitive once you see where the tumor is located and how it moves to get an idea as to what changes you might expect by performing a 4D dose calculation that is a motion inclusive dose calculation as opposed to just a static dose computation. So as I have mentioned at the beginning of this talk, we see the methods, we know what's available and what we can do about it, but we have to stop for a second and also try to figure out what is the end point of all these and what is the clinical significance of the differences that one can see between 4D and static or 3D dose computations. So I'm going back to the same study performed at the University of Michigan. As I have indicated a few minutes ago, there was a full 4D dose calculation that was performed, and then there was the static dose calculation from the XAL dataset. And the question was, how do we assess the relevance of the differences in doses between the 3D and 4D dose computations? And the idea in the study was that, well, we can say that the difference between the two doses would be perhaps clinically important if, for example, we would have to make a change in the prescription dose in the 4D dose calculation such that we have the same complication probability level for lung, for example, as we had in the static dose calculation. And from here, of course, the question becomes, well, what is a significant change in the prescription dose? I don't think the answer to this question is known, but perhaps the minimum change that might be clinically important could be, for example, a dose that equals the fraction size dose. So for the patients from this study, the prescription dose was 2 grays per fraction, and that's why these 2 horizontal yellow lines are shown here as a threshold beyond which we may say that, okay, these are clinically important changes. And as you can see, over 19 patients that had various motion amplitudes and tumor location, it turns out that only in 3 cases, the change in the prescription dose in such ISO-NTCP dose escalation protocol would be more than the size of the treatment fraction. And if we take a close look now, in these 2 cases here, the change in the dose would mean a decrease in the prescription dose. And if we look and see exactly what these cases were, we see that they correspond to situations where, first of all, the motion amplitude was above 1 centimeter or so. But more importantly, or actually equally importantly, I guess, there was just a hot spot that fell inside the normal lung. Whereas for this case here, where the indication was that maybe some dose escalation would be possible, it turned out that it occurred for one patient where the redistribution of doses in the 4D dose computation created a cold spot in the lung. When it came down to serial organs, we have found one situation where the effect or using 4D dose computation seemed to actually help understanding better what happens. For this particular patient, the prescription dose was in the static dose calculation was the maximum one that was allowed by an upper 5% limit in the esophagus NTCP for late toxicity. And the cumulative dose indicated increased probability for esophagitis above this 5% upper bound as a result of motion and deformation. Excuse me. A similar study was performed by Dr. Starshall and his collaborators at MD Anderson Cancer Center. And this table summarizes their results as far as the target coverage. There is no clear criteria, as I said, as to where a change is clinically important. So if the criteria was set arbitrarily at a 3% difference in the D99 value for CTV, their study indicated that replanning would be required in 6 cases out of 15. Now, if the criteria was relaxed to 5%, then there will be no replanning required. And with the criteria that would be set at 5% in D95 for the PDV, then replanning would be required in 5 cases. So again, it comes down to us not necessarily knowing very well what are the limits at which a 4D dose computation would maybe be required. They have also looked at changes in doses to various organs at risk, and I have extracted here the data for mean lung dose and the maximum dose to the cord. The doses to lung appear to be less sensitive to changes in the doses emerging from motion and deformation. But when it came down to the maximum dose to the cord, they found substantial changes, as you can see here, in 2 cases, which seems to suggest that knowing what happens with the serial organs may be more important than what happens in parallel organs. So the aim of this presentation was to basically review current approaches of computing 4D doses by doing full calculations, and also we overviewed some simplified methods. And also our goal was to present some results from photon radiation therapy studies that compare static and cumulative doses. Overall, improvements in patient-specific geometrical conformality are achievable, thus potentially minimizing the chances for in-field target misses. And improvements in the dose computation accuracy are expected as well. However, treatment plan evaluators appear to be less impacted by motion effects, although certain scenarios where 4D could be required have been highlighted during this presentation. I need to mention the fact that a number of important aspects have been left out of this presentation, such as the effect of residual imaging, artifacts, registration error, optimal margin definition, variations in patient model during treatment, 4D dose computations for stereotactic body radiation therapy, 4D for proton therapy, and so on. Although these issues have already been addressed to a certain extent in other studies in the recent years. What's for the future? Has 4D research reached a plateau? Well, I guess the answer is a solid no. But while we refine our way of managing breathing effects through 4D treatment planning, we should perhaps also focus on evaluating whether the clinical outcome improves, and we should try to better identify those scenarios where the whole effort would be truly justified. Thank you.